great to see some familiar faces and some new faces as well. And I welcome you to this month's session with our special guest, Dr. Sarah Colman, who is a staff psychiatrist on the geriatric inpatient unit at CAMH and a psychiatrist on the psychogeriatric assertive community treatment team with Reconnect Community Health Services. As well, she engages in outreach work to frail homebound seniors through collaborative models and with the help of telemedicine. She is the president of the Medical Staff Association at CAMH. She recently completed her tenure as the associate program director for the Department of Psychiatry, U of T, and she is an assistant professor at the University of Toronto. So welcome, Dr. Colman.
Thank you so much. Thanks for having me. Should I try and do that fancy share screen thing now? Okay. You let me know if it goes glitchy on you or if this is working well, okay?
It looks good so far.
Okay, great. So when I was asked to do this talk, I wasn't sure exactly what we wanted, but I asked Alan, he said this was a good idea. So you can, it's a small group and we'll try and make it as interactive as possible on Zoom, in this world of Zoom, and hopefully cater it to whatever your needs are and leave lots of time for questions. I have a bunch of slides, but I can skip them or spend more time on them. So feel free to jump in at any point. Okay, so basically the idea was I thought we'd talk about how we can keep our brains healthy as we age. Generally, when we give scientific talks, we talk about any disclosures that we would have, any funds we have from drug companies or other things like this. And I do not have anything to disclose today. I do not have any drug company funding or anything like that. I just care a lot about this topic and this population. So the objectives I thought I'd go over today are to appreciate the differences between mood and anxiety disorders in older versus younger adults and review the treatments, to understand the definition of dementia and what can be done for prevention of dementia and treatment of dementia, and then to learn about resources available to help manage both depression, anxiety, and dementia. It's a lot to go over in an hour, so it'll be like a Cole's notes, but hopefully helpful and interesting. But before we get started, I'm just wondering if anyone has any burning questions that they are hoping this talk will address so that we can try and incorporate them.
I'm thinking by the silence that maybe
the educator in me like waits till everyone feels really uncomfortable with the silence before I move on. But if you want to, if you think of any over the course and you want to throw them in the chat or anything, feel free, or we'll leave time for questions afterwards as well. Okay. Okay, so I thought though to make it interactive, I would start with a few multiple choice questions to test you guys. And this you could either put in the chat if you want, or you could just think it in your own brain. Okay, here we go. So the clinical features of depression that are often seen in older versus younger patients are, so only one of these is true. Psychotic symptoms, that includes hearing voices or feeling unsafe. Increased interpersonal sensitivity, so like drama, social drama. Mood that is worse in the morning and improves throughout the day, or increased sleep. Which one of these are you more likely to see in an older adult versus younger adult? So think about it for a sec. If you're feeling brave, you could throw it in the chat. So L. Nelson is correct. So actually, most commonly, and we'll get to it. I mean, all of these things can be seen in depression with older adults, but it's more likely for C to be seen in older versus younger adults. Okay, so one thing to point out is that it's not depressing to get old, that actually in general, like the average prevalence of depression is about 10% of the general population, so 1 in 10 people will be depressed. But in older adults in the community, it's only about 3%. It's actually lower. So older adults are not more likely to be depressed than younger adults. That changes if you go into long-term care homes or nursing homes. Then it's actually higher than the general population. It's 12 or 13%. And there could be, we don't really know the reason, but there could be lots of reasons. One of which is that if you have depression over the course of your life, you're more likely to develop cognitive impairment or dementia and require a long-term care home. And the other is, you know, what we've all seen in the news over the course of this pandemic is that long-term care homes can also be very depressing places, and certainly, you know, wouldn't necessarily cause a clinical depression, but enough of a toxic environment could do so. And so certainly there's work to be done in making long-term care homes more humane and enjoyable. So what are the risk factors for developing major depressive disorder? This picture really helps me remember some of the risk factors. One of them is being female. Another is being impoverished or having a lower socioeconomic status. Then, like everything in medicine, if you have a history of depression, you're more likely to get it again. Or if you have a family history of depression, you're more likely to get it again. And also early losses in life. Like significant losses early in life are more likely to cause depression. And these, when we see older adults with depression, they often have a melancholic depression. And what that means is they might not say that they're depressed, but they have this thing that's called anhedonia, which really means a loss of pleasure. So things that they previously enjoyed, it's very hard for them to enjoy. And classic questions I'll ask are like, can you get pleasure out of seeing your grandkids or things like that? And oftentimes they can't. Also, their mood is pretty flat. They may lose weight or have a significant loss of appetite. And they're either very slowed down or very agitated, sort of rocking, pacing around. It's hard for them to sort of sit still. Classically, they'll be waking up at 4 in the morning and just not able to fall back asleep and feel overly guilty for unclear reasons. And this diurnal variation, fancy language, is that idea of feeling worse in the morning, but it improves a bit over the course of the day. So that's classic for a melancholic depression. We often see that in older adults. Also in older adults, people will frequently not say they're depressed, but they'll have what we call somatic complaints. So soma is the body, right? And very classically in the tummy, people will feel constipated, or people will have stomach aches, or people will be nauseous, or really focused on their bowels a lot, and have an inability to experience pleasure as a result of this, but they may not say that they're depressed. There's lots of comorbid worries or anxiety. They may not be able to function as well with like cooking and cleaning and dressing themselves. They may resist care if they require care to be provided to them, and they'll often ruminate. And so that's when they sort of get stuck in a toxic loop in their mind and think about the same thing over and over and over again with lots of negative thoughts. And now psychosis is a big word that just means like a disconnect from reality. People think about psychosis generally, they'll often think about someone who has schizophrenia, who hears voices or sees things other people don't see, or feels like there's a conspiracy out to get them. That's not classically the psychotic symptoms someone will have if they're depressed. They'll have psychotic symptoms that fit more with this idea of depression, like it fits with being sad. So they'll feel like they're really poor when they're actually doing fine financially, and it's not in keeping with reality. Or they'll feel so guilty that, like, you know, it's totally unrealistic about like a tiny little thing. They're just like consumed by guilt. Or as I mentioned before, they're focused on their body and they might feel like their body's rotting away from the inside when it's actually not. Or they might feel the world is coming to an end. These kinds of thoughts that are not in keeping with reality, but they sort of fit with the valence of being depressed. And it's a serious disorder. So in fact, not anymore, and you'll see my next slide, but between 2000 and 2007, very old men were the most likely to complete suicide. And so we think about suicide among youths, which is terrible. Suicide at any point is terrible, but very old men are at a very high risk for completion of suicide. And sort of 2016 data, it's not as, you know, the 40 to 60-year-olds have, you know, climbed a little bit. It's still quite high though, still lots of concern there. So when older adults are expressing any kind of suicidal ideation, it's something to take very seriously, and specifically men more than women. So how can we treat depression? So first of all, psychotherapy, right? Psychotherapy alone can be very effective when someone has a mild to moderate depression. When someone's depression is very severe, they're too depressed to engage in the psychotherapeutic process, and they'll often need medications or other treatment modalities in order to get them to the place where they can engage in psychotherapy appropriately, right? To like loosen the screws so that they can actually engage in psychotherapy. Psychotherapy is less effective if someone is suffering from some level of cognitive impairment because they can't easily remember the process of therapy. So it's a bit harder, but we still try. And the types of therapy, these short-term therapies that have evidence in older adults, are something called problem-solving therapy. That one's the most effective in people who have some level of cognitive impairment. Cognitive behavioral therapy and interpersonal therapy. Interpersonal therapy has themes of grief and role transition. Those are classically quite meaningful in older adults because there's often issues around role transition or grief. And then my favorite kind of therapy is behavioral activation. It's a part of cognitive behavioral therapy. And there's just this idea of there's like a vicious cycle, right? If you're feeling down, you get out, you get less out of life, you get less enjoyment out of things, you stop doing things, so then you feel more down, so then you get less out of life, so then you stop doing things, and it's this vicious cycle. Versus if you start doing more of things that give value and meaning to your life, then you get more out of life, then you start to feel better, right? That's not to say that people can just like, oh, buck up and get out of your depression and start doing things and you'll get better, because that is really not true. But it's certainly a component of treatment that's essential, especially in older adults. And during the pandemic, what's been so difficult is figuring out what people can do when they're at risk, right? In order to actually be behaviorally activated so that they don't continue to fall into depressions because everything's shutting down. Don't worry about the details on this slide. This is looking at medication. The one little diamond I want you to look at is this one. Can you see my cursor or no at the bottom? Can you see my cursor? No? Okay. If you look all the way down and it says total and you see the little diamond right at the bottom, that is showing that medications, when you take them all taken together, work. Okay, it is more likely than placebo to work to treat depression in older adults. Okay, so each study itself, placebos are very effective for depression as well. So individual studies, when it crosses the middle line here, it's like almost equivalent to placebo. So, but if you everything taken together, when you study all of the studies together, antidepressant medications work to treat depression, and they work about the same as your cholesterol medications work to treat your high cholesterol. And this is a similar study looking at preventing recurrence of late life depression, looking at 8 of our like best kinds of trials, randomized control trials, sorry. And it also shows that if you stay on an antidepressant rather than switching to a placebo, like a sugar pill, you're less likely to have a recurrence of depression. And so all these studies taken together show that you should stay, if you've had a major depressive episode, you should stay on your antidepressant. If you go off of it, you're more likely to have a resurgence of your depression. We'll talk about how long. When you're treating with medications for older adults, for anything for older adults, you want to start low and you want to go slow. Oftentimes with older adults, you want to stay at a lower dose than you would at a younger adult because the body metabolizes things differently and they might not need quite as high a dose. That's not the case for antidepressant medications. You actually want to aim for the same dose as you would in a younger person, but you get there slower. So you start low, you go slow, but you aim high. And you need to wait like at least 8 weeks before you've decided this has failed. And you need to stay on it for at least 6 months, really a year. And if you've had multiple episodes of depression, you should probably stay on antidepressants for the rest of your life. Just like if you have high blood pressure, you should stay on your blood pressure meds. Or if you have diabetes, you should stay on your diabetic medications. If you go off of it, just like your blood sugar would go up, your depression is very likely to come back. And this one, okay, this is too bad you can't see my thing. If you look down 1, 2, 3, 4, 5, 6 down where it says sequential treatment program. So this is things towards the right-hand side of the screen means better. Things towards the left-hand side of the screen means less effect. So this sequential, the purpose of the slide is to look at sequential treatment program. And what that means is that's when you try one antidepressant, it doesn't work, you try another one, it doesn't work, you try another one, it doesn't work, you try another one. Doesn't actually matter which ones, just matters that you're actually trying one after the next, right? That works the best, better than any specific antidepressant, right? And what I'll see as a psychiatrist is that someone will get on one and stay on it forever and it's not working and they're still depressed. So you just need to keep trying, keep trying, keep trying, and that's what gets people better, right? Finally, we talked about major depression that has psychosis, that disconnect from reality. The best treatment in my view for that, so you can be on antidepressants plus an antipsychotic, you can, but they have lots of side effects. The best treatment if someone has either a severe major depression or major depression with psychosis or failed trials of antidepressants is electroconvulsive therapy. And I like to say this everywhere I go because ECT is one of the most stigmatized treatments that we have. When people think of ECT, they think of One Flew Over the Cuckoo's Nest. Anytime you see ECT on any kind of television drama, it turns the person into a vegetable, right? And yet we still provide ECT. Why do we still provide ECT if there's this terrible stigma? Because it works, right? When antidepressants work 60% of the time for major depression, ECT works 90% of the time, and it works faster. And in older adults, they can't often tolerate the side effects of these multiple medications very easily, but ECT can get them better and they can tolerate it. It's a brief intervention. It generally works very well. And I've seen miracles, and I've seen so many cases where people refuse to have it because of the stigma, and it's just heartbreaking. So any chance I get to share that ECT is very helpful. Look, there's risks to everything. You're getting a general anesthetic, so there's the same risk you get if you get a general anesthetic, for something else. But it's a very well tolerated procedure. It does not cause dementia, and it is not used enough because of the stigma that surrounds it. And I could give a whole talk about it, but I will move on to my next slide. Sorry. This is an opportunity for you to read this multiple choice while I go on mute so you don't need to hear the overhead call. Okay, so panic attacks, that's when all of a sudden you have a sudden surge of feeling very, very anxious, like something terrible is going to happen. Your heart's beating really fast. You get really sweaty. You feel like you're going to pass out, and it's like awful, and peaks in about 10 minutes and then fades off. Are they more common than in younger patients? Are they secondary to medical problems? Are they seen with major depressive disorder? Are they both? All of the above, or just B and C? Yes, Teresa and Nelson are correct. It is, or L Nelson, I'm not sure. It is, so they are actually less common in older adults than younger patients. There's actually a study that one of my old supervisors did where he injected what are called panicogens into people's bodies. So these things that make you have panic, and older adults mount less of a response. Your body just doesn't get as panicked as easily, but they certainly do happen in situations where, so that's why if an older adult suddenly develops panic attacks, you want to make sure there's not a medical problem. We'll talk about which ones, or that they have a depression, because panic attacks can happen in those contexts. So there's a decreased prevalence of anxiety disorder as people get older, but if you look at different studies, there's a huge range. So it's really hard to say. And I wonder if they're not looking at the right types of anxiety, right? What older people are anxious about is very different than what younger people are anxious about. So there's, as I mentioned, less of an autonomic response, less of an actual physical response to anxiety, and fewer panic attacks in general. But, and so less worries about family and finances, but more worries about physical problems, more hoarding we see, more worries about a fear of falling. And I don't think that the studies the tools that are used to ask about anxiety necessarily address geriatric related anxiety issues, right? So if you're just asking general anxiety questions about worries about family and finances, you get lots of no's from older adults because that's not their life stage. Whereas if you ask them about a fear of falling, you'd get much higher, and that's not on the lists, right? And so the words that we hear often are related again to like feelings of their tummy not feeling well, or feeling dizzy, or feeling shaky. They may not say they're anxious, right? So that also may undercall anxiety disorders in older adults. So what do we see? Where do we see lots of anxiety? We see if they have gastrointestinal illness. We see if they have hyperthyroid, so the thyroid working too well, basically, overactive thyroid. In diabetes, especially related to people having highs and lows, they can get significant anxiety feelings. Parkinson's disease, especially during freezing episodes, you can have terrible anxiety. If someone's anxious after heart surgery, there's a higher rate of mortality, and maybe the body knows something and is telling them something's not right here, something's not right here. And then cardiac problems, respiratory conditions like asthma or things like that, and vestibular problems, meaning when people get vertigo. They can lead to secondary and cyclical anxiety. So I'll use vertigo because I've experienced it as an example, right? I had like a terrible case of vertigo, and then I developed an anxiety disorder after, because anytime I would start to feel like I was about to spin, my cortex, the more mature part of my brain, would be like, oh my God, here it's coming again, right? And then I'd get dizzy, which was an anxiety symptom. And it was like this horrible cycle, right? And so I had to CBT myself out of it. But these things, like similarly, right? Like if you can't breathe, your brain's gonna be like, you can't breathe. And then anytime you get a little short of breath, you're not gonna be able to breathe. And then you hyperventilate and then you can't breathe. And it's this cycle, right? Or if you're having, some kind of arrhythmia where your heart's beating funny, your brain's thinking, oh my gosh, there's something terrible happening. And then your heart starts beating really fast. And then you feel like something terrible is happening. And so they can be sort of cycles. And so when that happens, you need to treat both the anxiety disorder and the medical problem, right? Just treating the medical problem, once the brain learns, oh, something terrible is happening, it's not going to shut down. It's going to keep being vigilant and trying to tell you there's something terrible happening, even if it's no longer happening. You need to treat both, okay? In general, with anxiety disorders, they are being treated with benzodiazepines. People have heard of lorazepam or temazepam or these kinds of things. Xanax, Ativan is the other name. That is not great because that does not actually solve the problem. And in fact, it's kind of like taking a glass of wine when you're feeling anxious. Certainly it will work in the moment, but in the long term, your body develops tolerance and you end up being more anxious or needing more and more of these medicines. And then when you try and go off them, your body's like, oh my gosh, I need more, and you get even more anxious. You get what we call rebound anxiety. Versus what are called antidepressants, but they're not really antidepressants. They're serotonin impacting drugs or norepinephrine impacting drugs. They impact on the brain hormones. Those over the long term help to decrease anxiety. They're not as much of a band-aid. They're more of a solution when it comes to medications. And if those are not tolerated or not working, there are other medications called pregabalin or gabapentin that can be used for seizures or pain that also help with anxiety. And then finally, as I mentioned earlier, cognitive behavioral therapy with a focus on exposure and breathing, right? So can you hear me okay, despite the noise overhead? Yeah, I'm gonna keep going. They're gonna keep talking. If you face your fears, the cortex, the more mature part of your brain, learns, I got this, and it can turn off the more primitive part of your brain that's saying, there's a bear, it's terrible, right? And it can help to calm you down. But you need to expose your cortex to that so it learns it's okay. And you need to do it in a graded manner, right? So you don't start, if you have a fear of spiders, you don't start by like covering your body in spiders, because your brain will just shut off. But you could start by like thinking about spiders and looking at pictures of spiders, and then like going close to the spider and then holding a spider in your hand. And then your brain learns, okay, I don't need to be scared of spiders anymore. Spiders are okay, right? So that's the same for any kind of anxiety. If it's going out of your house, if it's being in large groups, etc., it's all the same. You need to expose yourself to it and then not run away until your brain learns, I got this, I can handle this. Okay, so some resources that are free in Ontario, I don't know if this is Canada-wide, so I only know Ontario, but some resources that are free to help with anxiety, depression are Bounce Back, Mind Beacon, and Ability CBT. All of them are free online resources that help with therapy and are provided by the government. So just 3 great resources to consider using if needed or recommend to your friends. And move on to the, okay. So now we're going to move on to dementia, which is also in the more recent Diagnostic and Statistical Manual, which is like the Bible for psychiatrists, called Major Neurocognitive Disorder. They decided to change the name. And I have a picture here of my grandmother and my grandfather. And my grandmother is brilliant, well, was a brilliant woman. She was a nurse and met my grandfather, actually, she was his nurse. And then went back to school when her kids were young and became a PhD English professor. And she also like wrote cookbooks and was in the Globe and Mail for her cooking and beat me at Scrabble all the time. And I started to notice that she was developing cognitive impairment when I beat her at Scrabble, because it was not that my Scrabble was getting that much better, it was that her Scrabble was getting worse. And I was sort of going into this field of doing work with people who have dementia as my grandmother was developing dementia, and saw her through like terrible end stage of this disease. So like to bring her up as sort of my own lived experience with this illness. It's not an easy illness for anybody to go through, or to be with their family members as they go through. But I wanted to talk about briefly what's normal when it comes to having some cognitive impairment as you get older, right? And so some things that are normal, and I'll speak to this fancy chart sort of more simply and get to just some like obvious examples in a second, are that like you may be a bit slower, your processing speed slows down. So you can still do the same thing, but you might just need a little bit more time. For simple tasks, your attention will not change, but when things are a lot more complicated, when there's a lot going on, it might be harder to pay attention to multiple things at the same time. And in our world of like phones going off, and where we all have ADHD because of all the different interruptions in our lives, and it can be harder for older adults to manage those competing tasks. And then in language, you know, generally language actually can like improve with age, vocabulary gets pretty good, but sometimes like if you're shown a picture and you need to name it right away, it might be a bit harder to do that as you get older. And again, for like finding your way around, simple issues, no problem. If it's quite complicated, it might be a little bit harder. And then executive function, that's like the executive part of your brain. That's the part that like organizes planning, things, or inhibiting things you're not supposed to say. That's mixed as you get older. And so when we talk specifically about memory, right, you may need a cue to remember something. So it's still there, but you may need a cue to withdraw it and remember a topic, right? It doesn't just spontaneously come. And so, for example, like, it would be a lot harder if you go to the grocery store without any cue to remember all the ingredients you're supposed to have, but if you had a cue, you'd be fine. Or if you were asked, yes, was this on your list, you'd be able to answer, right? Similarly, you might forget where you learned something, but you would still remember like the sequence of the things that you learned. And then you might forget to take medicine before you go to bed. But you would still remember things that you learned, like riding a bike or driving a car or things like that, if you just have normal aging process. When your brain changes as you get older, the volume of gray matter, so that's like the actual cells, decreases, the neurons, and like the communication between the neurons decreases. So ever since birth, actually, your brain is pruning itself, which actually helps you to be able to learn things. But then it keeps pruning and you keep losing neurons, and then eventually it becomes problematic. And so here are some signs that are of memory loss that are part of normal aging, right? So you may not be able to remember the details of a conversation or event that took place a year ago, normal. That's normal for me too. So that makes me feel okay. You can't remember the name of an acquaintance if they're not like a very frequent acquaintance, normal. You might forget things and events on occasion, normal. You might have trouble finding the right word a little bit here and there, normal. And if you're worried about your memory, but all of your friends and relatives are not worried about your memory, probably also normal. Okay. So then we'll go to mild cognitive impairment. And in the DSM, this is called mild neurocognitive disorder, not to be confused with major neurocognitive disorder, comma, mild, which would be mild dementia. Very straightforward. Basically what this is it's a noticeable decline in cognitive functioning that goes beyond normal age-related changes that I just talked about, but isn't impairing your function. So you can still do all the things you used to be able to do. You just need like tools and tricks, and you might need to take more notes. You might need to like have reminders on your phone, but you can still do everything that you were able to do before. There's no change in your level of function. So then what's major neurocognitive disorder, also known as dementia? That's if you have some kind of cognitive decline from a previous level of function, and it's not just memory. So learning and memory you'll see is this third bullet point. People often think about people having memory problems, but your brain does not only manage your memory, right? Your brain manages all kinds of things. So it's also attention to things. It's also the executive function that I talked about before, the organizing part of your brain, or the inhibiting inappropriate social response part of your brain. Language is a huge part. So you could have a decline in your ability to understand what people say to you or to be able to speak appropriately with language. And that in and of itself, even if your memory was perfect, would be considered major neurocognitive disorder or dementia. Or you get lost in space, or you can't do the things you were able to do. Like your brain can't tell your hands how to cook or things like that. Even if you can remember what happened yesterday, that's what we call praxis. And that could decline. So any area of cognition that declines, that interferes with independence, interferes with your previous level of functioning, and that it's not because of an acute medical issue, like an acute brain failure, which is what we call delirium. So if all of a sudden you have like a fever or a major illness and acutely you're having these problems, but then you recover, that's not dementia. Or another mental disorder like depression or anxiety, like we talked about before, could influence your functioning without it being dementia. Another way of thinking about it there are these 7 A's that have lots of, some of them many Latin words. So those of you who know Latin will be able to understand what these are. So anosognosia is not knowing that you don't know, right? Agnosia is just not knowing things anymore. Altered perception, so you may see things differently or feel things differently than other people. Apraxia is what I talked about before, forgetting the way to do things that you used to be able to do, like cooking or using a computer or driving. Amnesia is just forgetting. And apathy is just being content, not doing very much at all. Apathy often gets confused with depression because someone will sit around not doing very much and their family will say they're depressed. But if you can get them to actually engage in an appropriate cognitive activity, like appropriate to their level of cognition, they actually can experience pleasure and do things. They're not depressed, they just have apathy that goes along with dementia or major neurocognitive disorder. And it's an umbrella term. So people say, like, what's the difference between dementia and Alzheimer's, right? Alzheimer's is a type of dementia. It's the most common type of dementia, but it's one type of dementia, and it's the one that people think about because that's the one where your memory, short-term memory, goes first before you have other elements of impairment. But you can also have dementia because you've had little strokes in your brain. We call that vascular dementia. Or you can have this thing called Lewy body disease, which is related to Parkinson's disease. It's a dementia. Or you can have a dementia where the front part of your brain stops working first, the executive function. And so you remember most things, but you start to swear inappropriately, or you have significant apathy, or you become aggressive inappropriately, and you stop being able to plan things, even though your language is perfect and your memory is perfect. Or you could have a combination. So those are the most common types. And then these guys on the other side are the less common types of dementia. But there are many different reasons that your brain, you can have dementia. And the other way of thinking about it is like a chronic brain failure, right? Like over time, brain not working well as it used to. And it's growing, like the number of people with dementia is growing. So 2020, I haven't looked today, but apparently around 42 million in the world. And by 2040, that'll be double. 90% of people with dementia are cared by for family members in Canada. And the percentages increase significantly with age, right? So 8% of people 65 years and older, 35% 85 years and older, and then 50% of people in Canada are cared for by family members versus 90% in the world. So in the Western world, we institutionalize our older adults, and in other less developed areas, people are cared for in family systems. So when should you start to worry about memory problems? So if your memory loss is impacting day-to-day activities, if you can't do familiar tasks like using the computer or cooking, if you're having problems with language that are not just like the occasional word or the occasional name, if you're finding you're disoriented, getting lost, if someone is noticing you probably wouldn't, that your judgment is significantly impaired, if you become more concrete, so you can't think as abstractly anymore, if you're finding your keys like in the closet rather than in the place, or like more like your sugar in the fridge, or unless you keep your sugar in the fridge, but you know what I mean, like misplacing things significantly. If there are significant changes in your mood and behavior or changes in your personality, and if you've got this apathy, this loss of initiative, if your get up and go has like got up and gone, that's when you should worry. So if I were going to assess someone, whether they had diagnosed, whether they have dementia, the first thing I would do is take a very thorough history from them and a loved one, to be able to get a sense of the progression over time. I would do some physical examination and some laboratory tests. I would do brief cognitive tests. Not that they're necessarily going to give me the diagnosis, but they're going to help to complete the picture. So lots of people have heard of the MOCA, especially with Trump and the score that he got on the MOCA. So the MOCA doesn't tell you whether or not you have dementia, but it can help if you do one and then you do it a year later and it's gone down, and you sort of see over time that it's declining. Because people can have dementia, have a perfect MOCA, or people can have a terrible MOCA and not have dementia if they have like a lower level of education or English isn't their first language, but it's a useful tool. And then only for some people do we do brain imaging. You definitely don't need brain imaging for most types of dementia. It's a clinical diagnosis, a bedside diagnosis. And then here are the stages. I'm just mindful I want to leave time for questions. So the stages are, stage 1, there's no cognitive decline. Stage 2, very mild. Stage 3, they have difficulty traveling to new locations. They might be okay in their home space, but in new places, it's a lot harder, and difficulty handling problems at work. As it becomes more moderate, complex tasks are more difficult, like finances or doing shopping or planning dinner for guests. And when it becomes moderately severe, people need help to choose their clothes. They need prompting to bathe. So I'm just going to take a sip. And as dementia progresses, it gets more severe. They lose awareness of recent events and experiences. They need assistance with bathing. They can't toilet themselves, or they become incontinent. And then very severe, they sort of stop talking, down to single words, can't walk, can't sit, require help with eating, sort of total care. And all dementias by the end look the same. Doesn't matter if you have, once it progresses enough, by the end, by stage 7, they all look the same. And what I often get referred for are the behavioral and psychological symptoms of dementia, which are also known as reactive behaviors, which are also known as neuropsychiatric symptoms. That's when people get psychosis, they feel like paranoid, or they become aggressive or agitated or restless, anxious, etc. That's commonly what I will see people for. So what are the risk factors? So the biggest one is age. We are like, that's the biggest risk factor for developing dementia. Unfortunately, being female as well, but I think that's because women live longer. Very few people have this, but there is like a specific subtype where people can have the genes to develop dementia. And then finally, it's really important to manage hypertension, diabetes, stop smoking, and treat heart disease, because those impact your blood vessels, and your blood vessels go to your brain, and that can lead to dementia as well. So how do we prevent it? So you got to start young, and you got to exercise. Exercise is huge, important to keep physically active. The most evidence with respect to diet, people like all kinds of diets, but the most evidence is for a Mediterranean diet, so heavy on fruits and vegetables, heavy on whole grains, on healthy proteins like fish, limited red meat. If you smoke, you should stop smoking. High blood pressure should be managed, and you want to keep your mind active in any way that works for you. So you don't need to like buy fancy like Lumosity or whatever like that. Like you just need to keep your brain. You have to come to talks like this and then engage in them. Like you need to keep your brain active in any way that you can, and also keep socially active, which during this pandemic has been really hard. And so here are some activities that are associated with high cognitive function in older adults. That doesn't mean they're the things you need to do, right? It's just that we know that people who are high functioning older adults do these kinds of activities. So I'll let you read it rather than reading it out loud. Almost done. Okay, and then I'm not going to go into detail about the medications. Just suffice to say the medications don't work great. I'll say to people that, you know, if you're in the community and you want to stay in the community and you take these medicines, the average person will stay in community 6 months longer than if you don't take the medication. So it's not nothing, but it's also not so significant. And if you have side effects, it's probably not worth it. But certainly, as I've already mentioned, and I'll mention again, treating blood pressure, doing other treatments for stroke prevention, taking antidepressants if you're depressed, you know, would be very important to help minimize the chance of developing a dementia. And then also removing drugs that can be cognitively impairing. So those benzos that we talked about before, not only do they make people more anxious over time, they also make people fall and break their hips, and they also make people demented. So benzos are not great and should be, if possible, weaned off and stopped. Other sleep aids people take over the counter, like Gravol and stuff like that. Any medication that we call anticholinergic, but anyways, lots of medicines for incontinence, for example, can make you more cognitively impaired. Alcohol. So alcohol, if you're drinking a mild to moderate amount, like about 2 glasses a day, apparently does not cause dementia, and in some studies maybe even prevents. So if you're drinking a little bit, it's okay. I would never suggest people start drinking. The problem is when people develop their dementia, then they like forget that they had their drink. They're like, oh, I'm gonna have my drink. And then they have another turn. Oh, I'm gonna have my drink. And then they have oh, and then it turns into a problem. And that's certainly, too much alcohol is certainly cognitively impairing. So a little is okay, but too much certainly isn't, and probably best to avoid. So how do we treat dementia? So with mild cognitive impairment, there's therapies called cognitive retraining. If you have any difficulty with your hearing, getting a hearing aid, not being vain about it, very important, because if you don't hear things, you can't lay down memories, and there's clear correlation between hearing impairment and dementia. We don't know what's the chicken and what's the egg, but it's very important to have good hearing. When someone has behavioral activities, we put together a behavioral plan that takes into consideration the whole person and tries to like adjust the world that they're in to decrease the behaviors. Addressing caregiver burnout. When someone is caring for someone else that's dependent on them, and that person who's the carer is burning out, the person with dementia will have more behaviors. So it's a dyad, and you need to treat both parts of the dyad, and you need to make sure you take care of the caregiver. And then I won't go into driving, but you need to take away people's driver's licenses. That's the least favorite part of my job. Okay, almost second to last slide, I think, or third to last slide. So this is my other soapbox that I get on. I think it's so important. We don't talk enough about death and about advanced care planning, right? And so have conversations with your loved ones about what you would want if you were not able to speak for yourself. What are your values? What's important to you? How you would like your death to be? Like, we're very scared about having these conversations. And then I get patients who now have significant cognitive impairment and we don't know what they would have wanted, right? So talk about it early, talk about it often. And I'll show you resources. So there's this death over dinner. I did it with some friends. It's this really neat thing where they give you questions to ask and you have a dinner party or a virtual dinner party, whatever you're comfortable with, and you sort of watch some things and listen to some things first and have conversations about death to help open up the conversation. There's also advancedcareplanning.ca, which is you can put together a whole like goes through your values, and then you put together a whole sort of advanced care plan that you can share with your loved ones. If you're a carer that's struggling, or you know of one, the Reitman Center has training for caregivers and support for caregivers, as does the Alzheimer's Society. An excellent book about dementia for caregivers is the 36-hour day. It's a little harsh on psychiatric meds, and there's some truth to that, don't get me wrong, but there is a place for psychiatric meds in certain cases, and Mace and Rabins are kind of against them. So that's my only criticism of the book, but aside from that, it's a great, great book. And then finally, you can fill out power of attorney documents on this last one. That's the link there. I've shared my slides, so you can feel free to use them or share them around, that you can get a power of attorney document and give power of attorney to people that you want to be involved if you can't speak for yourself. And that is it. I will stop sharing the screen and open up for questions.